Thanks, everybody. Thank you for being here. And Ariana, thank you so much for the invitation. I'll share my screen and we can get going. Let me do this. And okay, so I like to start by first talking about what inspirations and what brought me here. So hopefully you'll see three themes. We'll start with my clinical research and inspiration and thoughts there. This was a patient I'll start with that I saw literally within the first 6 months of coming to Stanford. I came from Valley Medical Center and was a primary care physician. This patient then was 32 years old. She had two young kids, many ER visits, usually always for abdominal pain and intractable nausea and vomiting. It was just really difficult to control, and she had spent many hospitalizations just with IV fluids trying to control the nausea and vomiting. By the time I saw her, our first clinical visit, she came to me on Dilaudid, which, if many of you aren't familiar with it, is a very strong oral opiate. And that was the treatment management that they had sort of come up with. It was the only thing that could help get her to stop vomiting. So I literally started seeing her and thought there has to be a better way to do this, and really started to think about how do we help patients, maybe not as dramatic as this patient, but how do we really start helping patients who have behavioral issues but present with very severe physical findings. So the objectives, taking that case into account, what I'd like to cover is really how stress can affect the body and disease, and then how that really led me to developing an integrative group medical visit model that we deliver here at Stanford. I'll give you specifics about the program, and then some study results that we have, and then how my next innovation, not really innovation, inspiration, was from my community-based partner, and how we transitioned this to community mindfulness-based interventions, and then a little bit about the outcome from the Alla del Estres program. Okay, so starting with stress, I always love sharing this because people always say to me, oh, you're saying to me that it's all in my head. And I say to them, no, it's literally in every organ system of your body. We now know, and I've been doing this research since I was a graduate student at my alma mater, UCSF. And we didn't have the biomarkers. We knew that people who had severe stress had more presentations, they had more hospitalizations, they had probably higher blood pressure, but we didn't have good biomarkers. And now we know that stress can affect every part of the body. So everywhere from migraines and headaches to actually cortical atrophy. And the cortical atrophy is specific, if you can remember a couple of bits of information, because it's going to come back. But the hippocampus, so for memory, and the prefrontal cortex, which helps us to process complex information and to make decisions. It's interesting, long-term stressor, very severe short-term stress can really lead to this cortical atrophy. Changes in mood, sleep disturbance, the cardiovascular system with elevations in blood pressure, ischemic heart disease are related to prolonged stress as well. Glucose, so prediabetes, diabetes, and interestingly enough, a weakened immune system with increased inflammation and a decreased ability to scan for viruses and precancerous cells. And all the way down to the DNA. We now know from colleagues at UCSF, Elizabeth Epple and Blackburn, they have done this work looking at stress and how it affects the telomeres. So the terminal ends of the DNA strands are weakened. So that DNA unravels, that cell destabilizes, and they're even using that as an early model for premature death. So it's not just in your head, it's everywhere in your body. There are links now between stress and disease. So again, when I started this work many years ago, we weren't measuring C-reactive protein. We didn't know about interleukin-6. And now we see that some of these substrates are really what are associating stress with atherosclerosis, so that ischemic heart disease, those heart attacks. We always thought that the glucocorticoids were related to the diabetes relationship between stress and disease, but then some of these other mediators of stress have really led us to believe that there are models of depression being an inflammatory process, and that the neurodegenerative disorders like Parkinson's disease have a very, very high relationship and link to inflammatory markers that we see with stress, and even down to specific cancers like breast cancer. Okay, so what does that mean for my patients in primary care? When I was a resident, I actually thought I was actually a medical student, was going to go into psychiatry because I was very interested in behavioral issues, so anxiety and depression. And then I did my first rotation in medicine and thought, oh my goodness, 30% of people who go to primary care clinics have an associated mental health disorder. So anxiety, the prevalence in primary care is about 20%, but about 40% of them are untreated. These patients present with higher physical symptoms. So think about that case that I started with. They also incur higher medical costs. My patient, those hospitalizations, repeated scannings, I literally put in her chart, please stop scanning her in big letters so that the ER would quit ordering CT scans. They were looking in the same place and missing the big picture. Depression in primary care, a lower prevalence, but also with lower detection rate and treatment rates. And there is a higher incidence of worse disease, chronic disease outcomes. We used to think that it was because in depression, people weren't engaged in treatment. And so they didn't take the medicines, they didn't follow up with their appointments. But now we're thinking it's more complicated. And if you remember the previous slide, what I mentioned was there is an inflammatory component to depression. We see that, and there is an inflammatory component to a lot of these diseases. So bringing together the stress, the physiological mechanisms to stress, to disease, and then their presentation in primary care. The other key component is that patients actually prefer to be treated by their primary care physicians and in primary care. So we do better when we treat these patients in our own clinics as opposed to sending them out to subspecialists. But what are the treatment challenges in primary care? So for the case that I presented initially, it was really time constraints. It took me a couple of visits before I said, this is not gastrointestinal, and this is not neurological, this is behavioral. There's also a high rate of recidivism. I see a lot of patients, and in the early days was seeing a lot of patients who would come in to see me in some crisis, and we would talk about the things that I'm going to bring up with the Beyond Stress program, and then I wouldn't see them again until the next crisis. So let's transition from how I spend my day, 2 days of the week, and how I spend it 1 day a week. So on the left, you'll see this little image of a physician running into these individual groups, or individual rooms. I don't have that many. I only have 2, but let me tell you, I am running back and forth all day Monday and all day Tuesday. But Wednesday, I get to do this. I get to actually see patients in a group medical visit format, and it makes all the difference in the world. So why is it so important? Group medical visits can accommodate many conditions and topics. I put here chronic medical diseases like diabetes, hypertension, COPD. But it can also be conditions that you see repeatedly. So for me, the people with severe stress, the depression, there are group medical visits in our weight loss clinic around obesity and weight loss. The other idea is medication visits around complicated medications. Some are like Plaquenil, Coumadin, and even the antidepressants that we prescribed. The other category to think about is conditions that you see a lot of, or you're interested in educating patients with. So prenatal care, healthy living, exercise, weight loss. I had somebody yesterday bring up, what about a sleep group medical visit? I was like, yeah, that's a great idea. You do need a high enough patient population that you can recruit from, because it's not for everybody. Not every patient likes to get their care in a group medical visit. So I really encourage people to look at that, but you need to have a large enough patient population to recruit from. The format for group medical visits, the size, I tell people it's really up to you. There is a sweet spot. It's typically between 6 and 12. I say around 8 is a good, nice sweet spot for me. I've had them as high as 12. It's a busy group visit, but it absolutely works. The time is typically, when you look at the literature, it's 1.5 to 2 hours long. The providers are different. They can be health coaches, nutritionists, diabetes educators, social workers, nurse practitioners, physician assistants, RNs, and MDs. For group medical visits, they're billable visits, so it has to be a billable provider. The style can be from a single series, like a prenatal visit, all the way to a series, which is what I run. And then the components of group medical visits tends to be a one-to-one check-in. You have to have that. There has to be some documentation that the billable provider had a one-to-one contact with that patient. But you can do it in the group visit setting. I do my one-to-one check-ins in the group setting. And I basically say to people, share what you're comfortable sharing in the group, but tell me how you're doing. How's your meditation? How's your stress? How's your anxiety? How's your pain? How's your sleep? Whatever it is that brought them to the Beyond Stress program. There's educational topics, discussions around those, really helping people to learn what it is that is modifiable in terms of their behavior. And then there's always, or very typically, an experiential component. So yoga, mindfulness, there's cooking classes as well. So what are some of the benefits? So patients definitely, it combats isolation. It has been proposed, definitely. Jeff Geller and others like Kirsch have talked about this. Patients learn from each other. So not only do they hear me giving feedback to one patient, but they are able to hear me do that repeatedly in different scenarios. They hear from each other, and so they share best practices. And they also see me interacting with somebody else, not just me interacting with them. And for the provider, you are able to spend more time educating. You get to hear a lot more. I definitely hear things that even the patients in the Beyond Stress group haven't shared with their primary care physician, that then I will message their PCP and say, hey, just letting you know, be aware of this. And you definitely get to know patients better. So what are the outcomes? The outcomes definitely suggest that there is both higher patient and doctor satisfaction. For the doctors or the providers, there's less repetition, there's more time for education. Disease specific are different. I picked diabetes here, but I just want to say the findings are impressive. We are spending hundreds of thousands of dollars, millions of dollars in the United States to try to get some of these outcomes. So there's been demonstrated decreases in the hemoglobin A1C, which means a better control of the diabetes overall, 88% improvement, as well as blood pressure, which is really important in diabetes. That's a 66% improvement. Reaching the goal, A1C went from 27% in one study to 50%. And also in terms of improvement of diabetics' kidney function, which is also a really big parameter. There's also data showing reduction in ER visits as well as hospitalizations. And you can imagine when you're seeing people in a group, you're saving some one-to-one clinical appointments. And so you increase your clinical access. I always put the slide in here because it gives me a time to just take a deep breath and really start to transition to my favorite part, because so far I've just given you all of the alarms and now hopefully I'll give you some of the wonderful solutions. So take a deep breath with me here. And let's move on to mindfulness. So mindfulness, we know that mindfulness-based interventions absolutely reduce stress, anxiety, and depression. I tell people that's no longer a question as it was, when I was doing my graduate work at UCSF. Now we're talking about what types of interventions are effective. How much mindfulness do people need to do? What kind of mindfulness? It's more, we're also looking at what are the neural mechanisms behind the mindfulness that's helping to make these changes. But there's no doubt, there's no question that mindfulness is effective for reducing stress, anxiety, and depression. And I will add pain, although while I'm focusing on stress, anxiety, and depression. Okay, I hope you remembered some of those findings from that very early slide on the effects of stress on mindfulness. This is what I found so astounding, and we didn't have this data again when I started so many years ago. Mindfulness has many opposite effects of those of stress in the body. So the physiology is changing when we are practicing mindfulness. So just like severe or prolonged stress can decrease the hippocampal and the prefrontal cortex size, the size of those brain regions, mindfulness, we have found with long-term meditators, increases cortical thickness in those same areas, in that hippocampus and that prefrontal cortex. Mindfulness will decrease the anxiety and the depression. It will improve or decrease insomnia. It actually decreases inflammation. We have a decrease in inflammatory markers at about 6 weeks. It will decrease your blood pressure. We see this in studies with hypertensive patients. And what's really astounding is that those two same researchers have also demonstrated that after 6 to 8 weeks, there's an increase in telomerase. And telomerase is the enzyme that helps to stabilize that terminal end of the DNA. So I always do this when I'm teaching patients, but the DNA strand here and the telomeres are on the ends of them. And so that telomerase helps to build up that terminal end of the DNA and strengthen that strand. So very impressive. Not only is it helping the mood, it's changing our physiology. Okay, so what about the whole package? Like, how can we incorporate all this? And those are the integrative group medical visits. Okay, so mindfulness-based group medical visits are definitely feasible and acceptable in cancer patients, and that was demonstrated with colleagues there at UCSF, Mishra and Chloe Artrea and their group. It's definitely effective in reducing pain, depression, and sleep disturbance in urban underserved patients. So Paula Gardner's group has demonstrated that. And we found effectiveness with reducing postpartum depression in Latina and BIPOC patients, and that's with Duncan and their group. So how did the Beyond Stress, how does that come into play? This group medical visit that it's now been running, I want to say 8 years at Stanford. It depends on the group. So I put, they're 6 weekly regardless. Here they've been 6 weekly. In the community, I'll share their, they can be 6 to 4 weeks, but we've done them here either 1.5 to 2 hours long, depending on the group. The format, as I mentioned already, we have the check-in, the one-to-one that I do in the group setting. There's an educational topic. There's definitely a meditation component. And then I really emphasize action plan. There's data that by setting an intention or an action plan at the end of visits, people are more likely to be able to make and sustain their behavioral changes. The components, I used to think in the beginning it was all the mindfulness, and now I really believe the supportive component, so the social support component as well as the education are big pieces. The outcomes that we've measured have included blood pressure, heart rate, GAD-7, which measures anxiety, and then the PHQ-9, which measures the depression. So the topics that we cover are stress. So what is it? Definitions, symptoms of stress, sort of like that diagram, but I let people tell me what and share what are their symptoms. That mind-body connection. So I do talk a little bit about the physiology and what's that mechanism. How is it that my thoughts, my mood, how is it that that's changing systems in my body? We spend 1 week on meditation, so we review different types of meditations, as well as what is the data that's showing that the meditations are effective. We spend week 5, if you're not meditating yet, we really want to work on barriers and how can we help you overcome barriers. And then we spend week 6 really looking at different modalities, different lifestyle modalities. And I say that these are parasympathetic, or that soothing part of your nervous system. So things like exercise, social support, art, healthy diet, so a low inflammatory diet. We'll talk about those things in week 6. And then we spend a lot of time really encouraging people on community-based resources where they can find support and continue to work on their practice. The meditations, I really believe, not one fits all. And so we explore 6 different types of meditation. So breathing, guided imagery, body scan, gratitude, compassion. And then we used to do yoga when we were in person, and now we do a completely different type of gratitude meditation. Okay, so what's the effectiveness? That's the methods. We collected data. We had for this study about 52 patients, and we collected the data. It's an observational study. We looked at the pre-post findings and found that both the anxiety and the depression scores were significantly reduced at the week 6 compared to their pre-session scores. We didn't find significant changes in their heart rate, systolic or diastolic blood pressure. It was all in the right direction, meaning that they were all reduced, but it wasn't significant. And I think it's probably because I wasn't measuring in people who were specifically hypertensive. Here is just a visual of those reduction across the 2 scores. Okay, so that was the first group that we did, and then we came up on COVID. So that in-person group, I actually had a group that we were meeting in person, and then we got the stay-at-home orders, and it was at about week 3. And it took me about 2 weeks of really trying to figure out how do we transition the group. And what we did was we just flipped it. We transitioned them very rapidly to a remote group. And the data that I'm going to show now just really was how did that work? There's precedent for it. This was a 6-week remote mindfulness group for cancer survivors, and it had showed that there was significant reductions in anxiety, depression, as well as social isolation. And so remote mindfulness groups, and this was a 2017 study, so there was precedent for doing it remote. And I'm really glad that we didn't wait. I was mostly worried about the patients, especially in that stressful time. So the specific aims was really to describe the procedures and then determine acceptability and feasibility. And we did that really through not through surveys, but through interviews. We really found that the provider needed to adapt. You can imagine. So I had not been using Zoom very much. None of us had really. I think our Department of Psychiatry had been seeing patients through Zoom even before the pandemic, about a year before, but the rest of us really didn't have a lot of experience. And so one of the big findings here was that it did require some provider adaptation, really talking about confidentiality around not having anybody else around in the room that could hear the conversations or that can see the patients that were participating in the group. And then really the facilitation. We asked people to keep their cameras on throughout the 2 hours of the 6 visits. We tell people it's okay, I tell them it's okay if you want to turn it off, if you want to step away for a while, or, go to the restroom or get something to drink, or during the meditation, but during the group to actually please keep your camera on. We felt that was really important for patient engagement, as well as a confidentiality. We also found that it required additional staff support to get the forms out. We were still mailing them out in paper form to schedule, and so we developed a really specific timeline for how to connect patients to these visits. The focus group themes, patients were really grateful for the continued support. Remember, they had just been issued. We had just been issued those stay-at-home orders, a really stressful time. People did talk about the convenience of remote visits, which I thought was really important. It's interesting, the interpersonal connection they felt was mixed, and this was early on, and the preference for future sessions remotely was also mixed. I think that we haven't done any new focus groups, but I actually think that has changed a little bit. People are now used to the remote visits, and the feedback that we're getting is that they actually prefer, it's easier for them to attend. So that was that second really project that we did. And then the third project with respect to the primary care group is really looking at in-person versus the remote integrative group medical visits, and really trying to look at comparative effectiveness. So really, are the remote visits as effective as the in-person visits are? And then I really wanted to look at suicidal ideation. We're doing the PHQ-9, so we're doing the full PHQ-9, which asks about suicidal ideation. I had seen decreases, but I wanted to see if that was a significant change. So we're just analyzing that data. That's really going to be sort of like the fifth paper in this whole bunch. So this is preliminary data, but I really did want to show it. The primary outcome when we did the studies and we controlled for a number of sessions attended, as well as any medication changes, what we found was that both the in-person and the remote had significant reduction, that's these two boxes, in the anxiety scores as well as in the depression scores. So not only, so they were both significantly reduced, but also this difference was not significantly different. That's this p-value that you're seeing here. So the difference in the change score was not significantly different. So both the in-person and the remote significantly had significant reductions in depression and anxiety, and those differences were not different, suggesting that they're equally associated with equal amounts of reduction. The suicidal ideation, we had really small numbers here. In the in-person and remote, I think it was like 8 and 11 patients across, and this sample size was 55. Sorry, I don't have those numbers, and this was 99. So we didn't find any changes here. Okay, so let's transition briefly to over to the community. So just like that patient in my primary care practice was really the focus and the inspiration for developing the group medical visit, I definitely had some goals for the community. I really wanted to expand to my community. At Stanford, I don't see very many Spanish speaking, and knowing that this is something that could be important. So I wanted to expand to the community. I wanted to translate it into Spanish and culturally adapt it. And then I really wanted to establish a community partner. So what's the data that suggested that this would be beneficial? Well, Latinx is, we as a culture actually favor behavioral over pharmacological treatments for depression and anxiety, and I will say for many conditions. So this also tends to be a trend when we look at diabetes and hypertension. But Latins their engagement in mindfulness-based interventions is significantly lower than when we compare it to non-Latin white patients. So the desire for non-pharmacological treatments is there, but their engagement isn't. And there's different reasons why this might be. That's a completely different talk, but there is certainly a lot of research, a lot of discussion in the literature around why this is. So this leads me to our project addressing mental health disparities in the Latinx breast cancer patients. So why breast cancer patients? 1 in 10 Latin women will be diagnosed with breast cancer compared to non-Latinx white women. They're diagnosed, however, at a later stage, and they have a higher prevalence of depression and anxiety. So an important population to really reach out to. The specific aims of this project were really to translate and culturally adapt the Beyond Stress program, to train a community partner. This ended up being my colleague who is a community health worker, to facilitate the mindfulness-based program, and then to determine acceptability and feasibility as the primary outcomes. And we also looked at preliminary effectiveness. Our methods, this was a randomized controlled trial. It was a small study. We were hoping to randomize 40, and it was during the pandemic. So our inclusion here was Spanish-speaking, identified as Latinx with a diagnosis of invasive breast cancer within the last 12 months who were in active treatment. And we included endocrine treatment as active as opposed to survivorship category. The outcomes, as I said, were acceptability, feasibility. We again looked at GAD-7. This was a community-based population, so we weren't able to administer the PHQ-9. So we used the CSD for the depression scale, and then we looked at sleep as well with the PROMIS sleep disturbance scale. This study we looked at 3 months out. So it was pre-post, so week 1, week 6, and then 3 months post-intervention. And I just want to park here a little bit and just talk about the cultural adaptation. There's really a lot that I recommend that people think about. People think that cultural adaptation just means translating an intervention. And I want to start with the translation and just say it's not that simple. We had it translated. We translated the Beyond Stress program. And then I met with my community partners and we literally went through each of the 6 sessions. And there were 3 of us and from different Latin backgrounds. And it was interesting because my community partners were able to say to me, that's not going to resonate. Like it's translated, but that's not the word that we would use. And then the one of Mexican heritage would say, this will resonate better with this population. The other one was of Costa Rican heritage, and they would say, okay, but that doesn't really resonate with us, and we'd have to find a word that fit both. And so really thinking, if you're going to do something in the community, really thinking about the population and really working with your community partners to hone it in. I've done this twice now with 2 different community partners, and we had the same experience. I thought it was so interesting. So thinking about the specific population that you're going to be working in. The New York Latin population is very different from the Northern California Latin population, okay? And so really reviewing the language, the translation with them is important. The content, we spend week 1 talking about stress, and week 2 for the cultural adaptation, we ask them, you tell us, you define what is stress to you? We didn't give them the preformed definition. We really wanted to engage them and have them define it for us. We made practice modifications, so appreciating that many of these women, the majority of these women, I will say, were working, had young children that they were caring for, or were caring for older adult parents, and were struggling during the pandemic with housing insecurity and food insecurity. And so we really emphasize shorter meditations. So can you take 5 deep breaths when you're feeling stressed? Can you do a gratitude list? Can you just, close your eyes and pause and just list 5 things that you're grateful for? So really trying to focus, living mindfully, stopping and using a short intervention is what we called it. We did say, the more you meditate, the better. And we gave them links to meditations, but really making it okay for them to engage in these shorter meditations. We acknowledge familismo, and that is just the importance of family. We didn't want to say you have to just take care of yourself. And what we said is we know how important it is to be there for your kids, to be there for your family, to be there for whoever it is you're caring for. We know that that's really important. And this will help you to be able to be there for them. Spending this amount of time taking care of yourself will make you more able to be there for the family. We really emphasized a safe practice setting, knowing that many people had experienced some form of trauma. And so offering meditation modifications like meditating standing, or we had one participant who would walk. She would be walking as she was on her phone participating because she just felt that was just more comfortable for her. And then finally acknowledging spirituality. It's important in this culture. And so really saying mindfulness is available to people with a spiritual background, without a spiritual background. It's open to everybody, and just making it a safe place. Some people would talk about their faith. Some people talked about religion. And we just acknowledged that that was all fine. The community partner that I worked with was Latina Contra Cancer in San Jose, and the facilitator training. Our facilitator was able to see me do one 6-week session complete in English. We then reviewed the 6 sessions, as I said, both in English, and then we spent another 6 weeks, another hour devoted to the translation in Spanish. And she also attended the facilitator training through the Integrative Center for Group Medical Visits, Jeff Geller's group, and that was amazing, and I'm super grateful that that was available. Primary outcomes, so we set feasibility with 3 markers. So we looked at patients who attended the first session out of everybody that was registered, and we benchmarked that at 75%. The participants who completed 4 out of 6 sessions, we benchmarked that at 75%, saying 75% we would consider a positive feasibility outcome. And then we asked them if they were able to implement the changes or the skills that they had learned over the last 6 weeks. We asked them this at the end of the session, so week 6. That was a 5-point Likert scale, and we benchmarked that as being meaning positive feasibility if it was at or greater than 4. For acceptability, across each of the 6 sessions, we asked patients to comment or to rate if the sessions were educational and the practices were helpful, and whether the sessions were relevant to their life and or situation. 5-point Likert scale, and we benchmark that as equal to or greater than 4. Okay. So what were our findings? I love this image. It wasn't our participants, but this is what it looked like. It was just a bunch of us Latin women on Zoom. It was pretty cool. Here's what our sample demographics. We had 53 patients inquire. We randomized 31. The average age was 51. They were all female. We had 16 randomized to the intervention and 15 randomized to the waitlist control. The majority of those women were in the endocrine treatment for both those groups. We actually found that all of our feasibility benchmarks were met. So 75% of the participants attended that first session out of all of those that had registered. 96% of the participants in the active intervention group completed 4 of the 6 sessions. And we had a 94% score. The mean there was 4.3 on that Likert score for the question that if they were able to implement skills or changes that they had learned. So all the feasibility benchmarks were met, as well as the acceptability benchmark. So when we looked across sessions, here, this column on the left, for both of the questions, was it helpful and was it relevant? And you can see that they all scored 4 or above. And then for the preliminary findings of did it reduce their anxiety and their depression scores, it was interesting. We found a significant reduction at 3 months. That was really interesting. It was, again, the first time that we didn't see it at 6 weeks as we had with the primary care population. It was a different population for sure. One of the things that we thought is we really needed a larger sample, but nonetheless, the finding was there at 3 months. We didn't find it at 6 weeks. We didn't find, although we found a decrease in the depression scores, that was not significant, and the sleep was not significant at all. Okay, so my community partner and colleague literally said to me, Maria, okay, but now we have to expand this. You need to expand this to everybody who needs it, not just to patients with breast cancer. And that'll bring me just to mention our last 2 projects. So one of the goals, one of the things that I had done in primary care was to, this was Jeff Geller's suggestion, was to not just have the 6-week groups, but to really have a place where people can keep coming back to. So at Stanford, I developed not only the 6-week groups, but I have monthly refreshers. And these are topics that we cover in the monthly refreshers. We've now been running them almost 3 years. So we took 8 of those. It took us, this was a year's project, but we took 8 of those, translated those trained my colleague to deliver those. And then those were continuation refresher groups that we did for the Spanish-speaking population. And then these are the topics that we covered in those, the same format. These were just the educational topics that we covered for those 6 sessions. And then I just would like to spend the last minute or two talking about the current partnership that I have with Samaritan House. Samaritan House is a nonprofit in San Mateo County, and they really deliver wraparound social services. So they have a free medical clinic, a free dental clinic. They provide some eye exams. They have a food pharmacy. They have medical free medications that they're able to dispense. They have a partnership with San Mateo Community Hospital so that people can get mammogram screenings and lab works done there. They had a backlog in their behavioral health division. They also provide behavioral health. And so they brought me in asking me to train the director of behavioral health to deliver the Más Allá del Estres program to try to increase their access and decrease their backlog. And so we were able to do that. And I just want to show this, which is our next project. So we now have the Más Allá del Estres as the entry point for this community nonprofits behavioral health services. So everybody floats through them. There is some ineligibility criteria like a diagnosis of psychosis, schizophrenia, severe active suicidality. Those are some of the ineligible criteria. But everybody else, and that is the majority, it's over, I want to say 90% will filter in through this group. We have that established. And then what we're proposing now is to integrate a stepped care model. We've proposed a grant and are waiting to hear back for the implementation of this step care model. So essentially all their patients would come in through the Más Allá del Estres program, and we have 3 possibilities. They either graduate, finish the 6 weeks, and they improve, their symptoms are stable, and then we would refer them and continue them on the monthly refresher groups. We would have patients that don't complete the program. We'll reassess them and determine what's best, either re-refer them or send them over to the one-to-one therapy groups. Or the other option is that patients finish the group, but they're still not improved. And so we have a step pathway there to refer them to either specialty care or the one-to-one therapy. And so fingers crossed, that'll be the next step for the Más Allá del Estres program. Okay, so hopefully what I've been able to do is demonstrate how an integrative group medical visit can be implemented not only in the primary care setting, but it can be transformed into a community-based mindfulness intervention to target different populations. I hope you're convinced now that stress is an important link to disease. It's not just in your head or in our clients or our patients' head, but really it's throughout their body. Mindfulness is an effective tool not only to change the mood, but also to impact their physiology. Integrative group medical visits are acceptable and they're effective behavioral health interventions. I tell people these are not wellness groups. You'll feel well, you will feel better, but they're treatment interventions. We have that data now. And then community mindfulness-based interventions can address healthcare disparities. It takes a village. I'm so very grateful to all of my partners, both at Stanford and in the community. So I'm happy to take questions and would love your feedback. If you have a second and just scan that QR code, I would just absolutely love to hear your feedback. Thanks so much.
Thank you. There are a lot of great questions for you in the chat.
Ariana, is it okay if I just leave the barcode image up as I'm answering?
Sure.
Okay, awesome. Thank you. Just to give people that opportunity. Okay, go ahead. Thanks.
Yes, now we see it. Maybe I'll try to ask them in an order that will flow. So one question is, in your RCT, were you able to learn why 25% of people did not attend the first intervention session? Like,
Yeah.
were there practical barriers, et cetera?
Yeah. We didn't actually, how do I want to say this? We had we had a wonderful, wonderful research coordinator who would call and ask and remind them. The feedback that we got mostly, and this isn't a data that we collected, it was mostly her observations from the calls, were that people were either at appointments or they were at work. And so it was life. And you can think of those as structural barriers, if they didn't have to work. But I would say it was a combination of both. It was treatment, they had to make their treatments, they had to make their appointments and or work.
That makes sense. A couple of questions that people asked about sort of the content of group. One is if you could talk more about the anti-inflammatory diet that you mentioned and how that was incorporated.
Yeah. So in week 6 is when we talk about the different modalities, including, I always tell people, because stress is an inflammatory condition, really what you want to do is try to move more towards a more anti-inflammatory diet. One of the things that that includes is decreasing and so this is what we talk about, decreasing carbohydrates and processed sugars, as well as reducing alcohol. It's just a pure carbohydrate. And then one of the recommendations that I would do is give people that Andrew Weil, anti-inflammatory. Andrew Weil has a great website that talks about anti-inflammatory diets. But in terms of more specific and more sort of actionable feedback is really reducing sugar, carbs, and alcohol.
Question about kind of group content was, how has trust and integrity between patients and providers differed in the remote versus in-person groups?
Yeah, that's a great question. It's not anything I've measured. Yeah, it's not anything I've measured. What do I want to say? I'm thinking about the dropout rates. We know with group medical visits, I tell people a good number to follow is about 25%. So like over enroll by about 25%. So why do I bring that up? I haven't seen a greater attrition rate with the remote visits. I have not seen that. And so I try to, I guess what I'll say is I really try to develop trust, especially around the safety of group medical visits by really, I'll give you an example, there have been times when somebody is on the Zoom and you can see somebody walking behind them, i.e. they're not in a secure place. And I will take that opportunity and really say, okay, it's okay if you need to log off for this session or you need to, relocate, but I'm really asking you to please relocate so that this can be confidential, turn your back to the room, put some earplugs in. So I've really tried to address that in the group visits to gain more trust. I will say this. It is never not surprised me how forthcoming people are. I think it's more about sharing, and that it really just takes one visit, and it's not about what I do, it's really about what they do. And they start sharing. Yeah, so I think it really is what Jeff Geller talks about, the inclusion effect. I think that has a really big part about developing that trust. But great question. Thank you.
Lots of compliments about what a fantastic presentation this is. And then a couple people, someone asked if you could go back to the slide about logistical preparations that need to happen before each group.
Let's see, can I? I should be able to. Oh, yeah. I'll go through really quick. And if you search, this was a paper, and it's definitely all in the paper. So I'm almost there. This is what this one. So this is for the support And it's a timeline, like we purposefully wanted to give you from 7 to 10 days prior all the way to the week 6. It's like step by step what we do. So if you look, that's the 2021. So you can just search my name, scholarly articles 2021, and this one will come up.
Someone else who works in endocrinology asked if you have specific resources about doing groups for diabetes.
I don't, but please email me because they are around. There are a lot of people who are doing them. Even if you search group medical visits for diabetes, AHRQ, so ARC, the early data that they reported on the effectiveness of group medical visits was around diabetes. So diabetes it's there. You can just search. Happy to help you with that if you don't find what you're looking for.
And then let's see, couple of other questions. One was, after your first cycle of the Spanish groups, were there any interesting things you learned that you changed for future group cohorts?
Wow. It was a randomized controlled trial, so we really weren't able to change the methodology, but I'm just trying to think. And Nancy, my partner, Nancy Villarreal is on, I think, in the group. So Nancy, if you want to, if you come off mute, if you chime in, I can't, I know we actually didn't change the methodology. I think if there's Nancy, anything Nancy that you think of?
No, because we were pretty good about tweaking the verbiage.
Yeah.
And since you already had that experience, I think that was very helpful. You had the experience in English, but no, it was just such an awesome experience because we were able to see how it affected them culturally. And it was amazing to see that on the fourth session, we would have like an aha, or not us, but they would have an aha moment. And it was a really neat experience.
Thank you. Thanks, Nancy. And I'll add, one of the participants just, again, I think it was them, not us, in terms of tweaking, literally at the end said, no se olviden de las otras. Don't forget about the others.
Working on a group visit study right now where people keep saying at the end of the cohorts, don't forget about us.
Yes.
Come back to us.
Yes. Yes.
Related to that, sort of, someone also asked, how have patients after the 6 or 8 week period retained the practices that they learned in the group? And do you do check-ins after a certain period of time?
Yeah. Great question. Okay, I have one study that we published that I didn't show the data for. And then I'll tell you about the monthly group session. So the study that I didn't publish was the Beyond Stress program in the healthcare population. So we ran it for hospital employees here at Stanford, and we did pre-post, so week 1, week 6, and 3 months out. That was really compelling data. So significant reductions in anxiety and depression, similar to what we had seen in the primary care data cohort. We also measured burnout, significant reductions in burnout. And we looked at self-compassion, and there was a significant increase in self-compassion, which I was really excited about because I really feel like that might be one of the mediators. But in terms of outcomes, 3 months out, those changes, those reductions were still present. And so we had no contact with them in between. We had given them resources, a handout that we give everybody at the end to continue their practice. And then when we contacted them again 3 months out, looked at their GAD-7 and their PHQ-9 scores, they were still low. So we know it has the potential sustainable effects. The other thing is that I will say, with the monthly groups, we continue to measure their GAD-7 and PHQ-9 scores, and they continue to remain well below 10, which is mild symptoms. I would say we only have subjective data or reports. It's not even data. When Nancy was running the monthly sessions and we got women who had completed the 6-week session, we would always check in with how is your mindfulness practice? And many of them were continuing to use the tools that they had picked up. The short breathing meditation, the gratitude list. Noting was big. I want to say that. Noting the stress, we really work on that, right? To be able to note it, as opposed to just reactively respond to it. Noting was something that I recall hearing a lot from the Spanish-speaking populations. They could see it, and they said, "Oh, I can still see it," and then that reminds me to do my breathing. So we have we definitely have some objective data with the healthcare population, and then just the reports from when we were doing the monthly sessions.
Awesome. Somebody asked about places to get training, and I just shared the ICGMV link in the chat. I don't know if there are any other training resources you want to recommend.
Yeah, that's and I'm hoping that that they decide to. I want to say I looked not too long ago, and they actually had the videos of the training sessions, but weren't doing them live. But I'm hoping that's something that they're able to return.
Thank you so much.
Thank you.
People have lots of grateful things to say, and if folks want to come on video for a minute and just virtually applaud, etc. Really appreciate you coming to give this talk.
Thank you. Thank you.